There's no question that molecular marker testing has really transformed how we practice oncology in general, and especially thoracic oncology and non-small cell lung cancer management. But that's especially true for advanced disease, where we have many treatments that are FDA approved, but only available and appropriate, often as first-line therapies for patients with one of many, up to now about 10 specific agents for detectable targets. But you obviously only can use them when you find them. And that makes a lot of sense when you're looking for so many markers to do broad molecular testing with next generation sequencing. That's what is recommended per the NCCN guidelines. And I would say that's really an extremely appropriate approach rather than a piecemeal one looking for 2, 3, 4 at a time. You want to cast a wide net. And in fact, several of the markers that are not absolutely used for clinical decision-making in terms of what treatment to give may still be relevant. Things like finding TP53 or RB or STK11 KEAP1, these are associated with resistance and other factors that might help inform our understanding of the biology of the cancer. So you definitely want to get molecular testing on essentially all of our patients with at least advanced non-squamous, and many of our patients with squamous histology, certainly those with a little or no smoking history or mixed histology that includes some non-squamous. And the question is increasingly moving into whether we should do this for routinely for patients with earlier stage cancer. We have data to support excluding patients with EGFR mutations or ALK rearrangements from immunotherapy in the resectable population, patients who might go on chemo and nivolumab preoperatively along the lines of Checkmate 816. That excluded patients with an EGFR mutation or ALK rearrangement. So you'd want to look for those. And I think you'd also want to factor in information about whether patients had a RET fusion or ROS1 or any of the other drivers that we associate with, in advanced disease, poor or likely no efficacy of immunotherapy to help inform those decisions with the patient. And increasingly also for consolidation durvalumab or not in the stage 3 setting. So I would say that increasingly we want to get information at least about EGFR and ALK, but most likely would hope to get information about a broad range of markers. But it does create challenges. You need to have enough tissue, and that means that whether it's for stage 4, stage 3, or earlier, you are going to want to get enough tissue not just to make a diagnosis, but to be able to do molecular marker testing. Sometimes if we don't have that, we can do a blood-based test, a plasma test, but that is not as successful for a patient with early stage, lower volume disease as for patients with more advanced disease where we just may not get the yield for it. And we do need to factor in the time that may be required to get that result back. In many cases, in most patients, we can wait 2.5, 3 weeks to get the results back, but we certainly need to inform our patients about the value of this testing and why we need to weigh that against the time issue. It's a little less time if we can get a result by blood-based testing, a liquid biopsy. And it also helps to have the systems in place to send off molecular testing as early as possible, often reflex testing at an institution, rather than waiting until the patient is already weeks into their workup to begin to think about this. And then it does help to have a patient who is motivated now to get that result. Sometimes for, say, early stage disease, and neoadjuvant, or say with chemo and radiation, you can give the chemo and you're not deciding on whether to give immunotherapy right away, certainly with chemoradiation in stage 3. If you were thinking about chemo and nivolumab, we might sometimes give one cycle of chemo holding the nivolumab until we get the molecular testing back, and then give another 3 cycles with nivo and chemo together once we get confirmation that the result does not show a driver mutation. But we do increasingly need to think about how to juggle the balance between getting as much information about the biology of the cancer as possible against the issue of time, working with our patients on that. And right now we have the extra challenge that we don't have data really to strongly guide us, and we're left with a lot of room for judgment about this.